Our next speaker is Associate Professor Jaimie Shores from Johns Hopkins University School of Medicine, and he is the director of the hand and arm transplant program over there. And unfortunately, he was not able to join us in person, but he's joining online. So we're happy that you managed to make it for the talk.
Great. Thank you very much for having me. Can you guys hear me okay?
Yes.
All right, perfect. So, Paolo, that was an excellent talk. I always hate following other surgeons who show wonderful things, so I'll do my best here. So what I was going to talk about was making sense of some of the new contemporary surgical approaches for the treatment and prevention of neuromas. And we're going to isolate this to the context of limb loss, because there are some other things potentially we could do for people who still have their limbs intact. And let's see here, is this slide going to advance? Okay, these are my disclosures. I don't have anything financial. I will say I'm part of a hand transplant team, and so there's a bias in that I think there's value in hand transplantation. But I'll also say that we have this unit at Johns Hopkins. We've just renamed it the CALL unit, Center for Amputation and Limb Loss. We used to call it the CURES, a Comprehensive Unit for Extremity Restoration. I don't know why we changed the name. But through this, I think that we're one of the few places that can evaluate people for both transplantation, conventional reconstruction, and some of these newer things that we're talking about, like osseointegration with TMR and things like this. And I think that if you have, and I'm sure Paolo would agree with this, if you have a place that only does one of these things, if they only do hand transplantation, then everybody they see is looked at through that lens. Well, this is a hand transplant candidate. Can we force this person into our service line, providing the service that we know how to do and that we're interested in providing? And I don't want to be that kind of person. I want to be the person that has all the tools they can offer so that we can try to find what fits best for the patient, not try to fit the patient into the other thing. And so, so the partners that I work with, like Jonathan Forsberg, Mark Hopkins, Marlis Gonzalez-Fernandez, we all work together to try to find the right fit for the patient, and along with our transplant unit and my partners here, Gerald Brandiker and the rest of them. I'm also happy to say that we've been collaborating with Ricard and Max for a little while now, and this has been a vast improvement in the level of technology I think that we can offer patients. And so I'm very grateful and appreciative to them for tolerating us and being willing to work with us. So I'll start off by saying the current state of amputation, is really, it's an old-fashioned operation. It varies depending on what level you're getting it done and who's doing it. And this is a picture of one of my surgical textbooks for knee training, and it talks about essentially just getting good flat coverage over the bone, putting the muscles together to perform a myodesis, so you have some socket control, and then just pulling the nerves out, cutting them, and letting them retract back in with or without a ligature on them. That's called a traction neurectomy. And this is still what's taught in a lot of places today, and I would say this is, we can do much better than this. When we think about our nerves are kind of our body's built-in booby traps. They perform these really high-level functions that have exquisite physiology. And when you go and you cut one of these things, it's like you're putting a little bomb in there ready to go off in the patient that they could suffer with for the rest of their life from. So we want to do better than that, than setting off a little bomb inside them. When we look at studies that evaluate chronic pain in amputees, we know that a lot of patients have long-term residual limb pain, 50 to 85% in this study. This is another study saying that there's a broad average of 10 to 76%, but as high as 85% in stump studies. And there you can see a sciatic nerve neuroma on that MRI lighting up very nicely. And so our treatment for nerve pain goes back to the 80s when Lee Dellin, who's a hand surgeon here in Baltimore that I'm happy to know and be able to work with sometimes, and Susan McKinnon, who everybody in nerve surgery knows very well at WashU, did this study together where they would just take neuromas, cut them off, and bury them in muscle. And they found that this was a great improvement over just having a neuroma hanging out, getting stimulated. And so what they found was that most people did well. The risk factors for not doing well were people on workers' compensation, and so that would indirectly indicate that they had a financial interest in not getting better. Or if they've had 3 or more prior procedures for pain that didn't work. And we know that this is a risk factor for not doing well in most things in surgery. However, when we think about what they were doing, they're taking a nerve and they're just burying it in muscle. They're just essentially putting it in a cushion. And innervated muscle, meaning muscle that already has nerve control to it that's intact, it doesn't automatically accept new innervation. That nerve isn't able to just automatically grow new fibers to control that muscle so that it has a job to do and it's satisfied. It may just be put in a cushion that's not getting bumped on. And so that's what we want to do, though. The Shores philosophy of neuroma management. This is my own thing, so you can blame me for this if you don't like it. Nerves are like teenagers. You need to give them something to do, or they're going to get into trouble. Okay, and maybe I'm just projecting from my own adolescence. Maybe you all did much better than me, but I think this is true. These nerves need to have a function for them to satisfy themselves and the central nervous system. So giving them something to do, be it sensory or motor, I think helps with the chronic pain that people get from these. And so let's give cut nerves something to do. Now that may include giving the nerve back its original function, so we repair or reconstruct that nerve in an extremity injury. Or if there's somebody who's had an amputation, we can replant that amputated part right away. Or for people that can't have replantations and we're now, months to years down the road, performing a transplant for them and giving them a new limb for that nerve to control. Or we can give the nerve a new function in other ways. We can do nerve transfers such as targeted muscle reinnervation. We can do regenerative peripheral nerve interfaces, which is putting a small muscle graft around the nerve. And we can do vascularized direct muscle transfers, which is doing the same thing, but making sure that piece of muscle that's denervated is vascularized. And we can try to limit neuroma formation by stopping or exhausting regeneration. And people can do this with things like nerve caps or putting a long length of allograft on a nerve, which is called the bridge to nowhere technique. But I'm going to focus on these other things up above for now. So the best solution for an amputated limb in terms of its nerve pain may be to immediately fix the problem. So here's a patient of mine with a transhumeral amputation, and we were able to get that back on. And so this is, I think, the best case scenario for trying to prevent long-term pain. And I'm sure Paolo would probably agree with that. But we need other strategies because sometimes amputation, replants aren't possible or they don't work, like in this gentleman. And so how about transplantation? Paolo showed us great outcomes from the patient he just demonstrated. This is the biological prosthesis, right? We're going to give the nerves back exactly what they want, which is muscles to control, sensory organelles to innervate so they can provide feedback to the brain to satisfy themselves and the brain. So here's a patient. This is, we've performed transplants on 8 patients, 13 limbs. This is patient number 7, traumatic amputation of his arm. He's missing biceps, brachialis. He's missing triceps. He's got deltoid present there. So we replaced all of those things. Here he is about a year after his transplant. Here he is 2 years after his transplant. And you can see he's got a little bit of bulkiness on the triceps area where the skin flaps overlap. I revised that for him. But this is all innervated triceps. That's not his native triceps. Pretty incredible outcome. People can also have a lot of problems. This is also was a patient of ours who left our practice. And you can read about this in Wired magazine. This patient's not happy. While their hands work, there are a lot of other medical problems that come along with these. And so transplant's not the best solution for many people. It's probably not the best solution for most people even. So, but for the right candidate, this can be life-changing. Here's another patient, bilateral. And here are his osteosyntheses where we put his bones together, distal forearm and transhumeral. And for this patient who's a quadrilateral amputee, first soldier to survive in the United States military, losing all 4 limbs in the battlefield. And he's got a transhumeral and a proximal forearm. And these are his levels of these. And what you can see here is it gives them back their independence. Here he is driving in a hand-controlled F-150 pickup truck. It's called a Raptor. They're awesome trucks. I love them. And, Americans, we love our trucks. And here's the other one driving. And, when you let these folks drive you around town using their transplanted arms, you know that you believe in something. So that's the real proof that I believe in this. However, most patients aren't transplant candidates, but I still want to keep that nerve busy by giving it something to do. And so I think this is where TMR comes in. So targeted muscle reinnervation was described by Todd Kuiken and Greg Demanian. And it's a nerve transfer that takes a nerve that was cut that doesn't have a target anymore, and it transfers it to a muscle that is still present. And this was originally described for improving outcomes with myoelectric prosthetics for above elbow amputations, where traditionally these prosthetics would not perform well at all. And so the traditional way that we do is we take one of the biceps muscles, since you have two of those, we cut the musculocutaneous nerve that goes to that, we put the median nerve to that, we'll find the musculocutaneous nerve that goes to the brachialis, we'll cut that, put the ulnar nerve to that, find a piece of triceps that's got a piece of radial nerve going to it, we'll cut that nerve, and we'll take the more distal radial nerve that has nerve fibers that are bound for the posterior interosseous nerve distribution, and we'll transfer that up. And that will give people, you know, pretty good function. So here's our first TMR patient, and he's also had osseointegration that we didn't do, but we now do osseointegration, a lot of it here at Hopkins. And this is the APL limb, the modular prosthetic limb from the APL Applied Physics Labs here at Johns Hopkins. And this is him intuitively controlling it via Bluetooth controllers. We can do this for shoulder disarticulations as well by taking muscles they may still have, like their pectoralis major and minor and their deltoid, performing targeted muscle reinnervation for that. So here's one of our patients for that. These are their neuromas from their brachial plexus. And I don't know if I can get this video to work, but screen sharing, let's see. Well, I don't know if I'll work. I'm going to keep moving on so I don't destroy this thing. But at any rate, that can be a real game changer in terms of motorized control. The people that created this, again, created this for motor control. But interesting observations that they made after the transplant were that of 15 patients who had neuroma pain after their amputations, 14 had experienced near complete resolution of their pain in the transferred areas, and one had a substantial improvement. And so does that mean that you know, everybody who gets TMR should suddenly have an improvement in their pain? Well, it might mean that people's pain should get better. And why is that? Well, maybe they just don't have neuromas that are being stimulated all the time. Maybe that nerve has a job to do, and that's somehow satisfying it. Well, some folks from Walter Reed and Ohio State University and Northwestern here, they got together and said, well, is that TMR any better than our normal treatment for neuromas, which is just burying the nerve in muscle the way Lee Dellin and Susan McKinnon taught us to back in 1986. So they tried to create a randomized trial with 200 patients to evaluate this and split it into a bearing in muscle versus TMR. The study was stopped after only 28 patients, partly because patients figured out, a lot of these are soldiers and they all have support groups and stuff where they talk to each other. And they figured out pretty fast, hey, don't get randomized to that TMR group. If they randomize you to the regular group and don't put you into the TMR group, then just withdraw from the study and tell them you want TMR, because it was working so much. And they told each other. And then the other patients that were enrolled still didn't have that great of a reduction in pain as well as the TMR folks. So for phantom pain and residual limb pain, both at a year, the people at TMR had a baseline pain of 5.8 to 6.6, and that dropped to 2.6 and 3.7 compared to no significant change in the just burying your nerve in muscle groups. And then they went ahead and they did that in the crossover groups of people who had received the other treatment. They allowed them to go into the TMR group, and it still worked in those folks. And so interesting observations they made: the longer patients had chronic pain, the less chance they have of being completely free of pain, and the lower the benefit, though they still had a significant benefit. And there was no comparison to this other thing called RPNI, which is Regenerative Peripheral Nerve Interface, which has also demonstrated improved pain relief from neuroma pain. And here's a graph of that. We take a free muscle graft, and we just sew that around the cut end of a nerve after the neuroma's been removed. Paul Sedern has invented this from University of Michigan, and he has demonstrated that patients have had improvements in pain. He's also able to get this to control a prosthesis by putting a small wire in this muscle graft. There's another interface that's being considered using high-resolution ultrasound that can see these things try to contract. And he's gotten rats to control human hand prosthetics by putting wires in them. And so they're experimenting with prosthetic control in humans now with wires and possibly ultrasound control. But in a small group of patients over a very short period of time, they demonstrated improvements in pain. Now, if this study was longer, they would be able to demonstrate longer improvement in pain. But nonetheless, this is the study as we had it, but it showed significant improvement. So is there another option that's kind of between these? And there is. That's what's called the VDMT, vascularized denervated muscle transfer. And so we're using denervated muscle, which I think is important so that nerves have an opportunity to reinnervate it. But what's different between this and Dr. Sedurna's RPNI is this is vascularized muscle. I've gone back in on a couple of RPNIs, and because they don't have blood supply, they whatever muscle lives by diffusion into the muscle. And so as you can imagine, a lot of that muscle doesn't survive and it scars down and shrinks. And so I've seen that myself. I've seen RPNIs where you stimulated the nerve, you can see a tiniest little quiver of that muscle. I've seen RPNIs where you stimulate the nerve and nothing happens. So the nice thing about these VDMTs is they're vascularized, and there's a lot of available based on the perforator anatomy of somebody. So you can take a Doppler, find perforators. You can isolate a piece of muscle on that you can separate from its innervation and still have it alive and transfer nerves into that. So here's how that looks. The graphic above is the large nerve that we've just implanted into it that's regenerating. And it came out of that bed on the muscle where we cut the small nerve that was going into it, but extended it out on its blood vessels. And this is what it looks like in real life. These are pictures from Sami Tufaha, who was the lead author on that article, who's a partner of mine. So does it have to be one or the other? It doesn't. All of these things can help us depending on the setting. And so the way that I look at this, and here's a person who we're amputating the arm after intravenous drug abuse has resulted in osteomyelitis and lots of loss of bone and infection and things and a useless, painful hand. If we can do targeted muscle reinnervation, especially for things that we're trying to generate motor control for, say, a high order prosthesis, like a nice myoelectric prosthesis, I still think that with transcutaneous EMG-based muscle detection, that TMR is probably our best option. For nerves that I want to still have good opportunity for pain control, that we're not necessarily going to be doing transcutaneous EMG signals on, then I think VDMT and RPNI work very well, especially RPNI, because you've got as much muscle as you want. And on the VDMT, you've got as much muscle as you can find vascularized pedicles on. Another version of the VDMT is when you do a TMR on a muscle, you cut the main nerve that goes to that muscle, so you transfer the whatever muscle you want into that, but the rest of that whole muscle is still denervated, and it's not going to reinnervate for a very long time. And so you can take another muscle and plug it directly into that muscle further downstream, and you've done a giant VDMT to it, and it will locally reinnervate that area as well. And so we can do all of these things at once in patients so that we can both make sure their sensory nerves, the more minor nerves, are covered, as well as these major motor nerves. How about somebody who doesn't have enough implantation sites for TMR and a stump that's too short for traditional socket fitting? We can even bring more muscle in. So here I can do a vascularized free gracilis muscle. I can do TMR with the median nerve to that. I can do VDMT by putting the ulnar nerve directly into that. And then I can do RPNIs to the MBC, MABC, LABC nerves. And here's the, here are the nerves pulled out. And here's the free flap with the skin paddle on it. Paolo will recognize this. And here's before we do his osseointegration. I'll cut that skin paddle out and tighten things up. This is the compress device. We switched mostly over to Oprah since then. And here he is with his myoelectric prosthesis. And he's from New York City. And so he's going to tell me hello in New York City language here very shortly. Boom, there you go. All right. So, of course, there are way more lower extremity than upper extremity amputees, and so I try to help these patients with their pain using the exact same strategies, TMR, RPNI, VDMT. So I'll just want to plug the Hopkins Center for Amputees and Limb Loss and our osseointegration program. We do way more osseointegration in lower limbs than we do in upper limbs, and I'm very thankful to have Jonathan Forsberg and Marlies Gonzalez and Mark Hopkins who helped me with this. And we do OI of the femurs, humeri, custom glenoid OI. You know, we try to treat every patient as individual. And for anybody interested, here's the website. And here's a patient that Max and Ricard have helped us with a whole bunch. This is a patient who had a shoulder disarticulation for necrotizing fasciitis and sepsis. Absolutely horrible chronic pain, which is still a problem. We came in one stage, did TMR. I came back a year later and stimulated those TMRs to find the parts of the muscle that would stimulate. And then we took Max and Ricard's bipolar intramuscular electrodes and plugged these in to areas that would stimulate. And then we put in a custom total shoulder device that was designed by Jonathan Forsberg and manufactured custom with a labral reconstruction here. And then we brought him back after this later on again, 3 to 6 months later, we put in a custom we put in an e-OPRA device into that custom device. We hooked our electrodes up and ran them into that. And so we're starting the rehab process for that patient now, but it's a very exciting next kind of generation for us using the e-OPRA for more direct muscle control, which I think will allow things like RPNI and VDMT to be even more powerful in terms of motor control, since we're not relegated to just using transcutaneous EMG electrodes, which require higher signal. So other future developments, I think there's a lot of things besides just advancing the technology, having better bionic devices, having better nerve relay. It's considering other issues. We know that TMR doesn't take all the pain away. And we don't know why mirror box therapy and more cognitive behavioral therapy helps work on phantom pain and neuroma pain sometimes. So why do people with regional blocks who've had those peripheral nerves numbed up sometimes still feel the pain despite that? What happens to all the other axons when we do TMR? We're taking a giant nerve and putting it to a little tiny nerve branch. Only a minority of those fibers can grow down the nerve transfer, and only a minority of those things are motor fibers anyways. So there's a lot more going on to pain than just that peripheral nerve. The central nervous system is a big part of this. How do we help people who have centralization of their pain? I think that cognitive behavioral therapy that incorporates virtual and physical components that work off of direct motor control can help this quite a bit. Hooking these nerves up in people to control an avatar in a virtual space can help them rehabilitate. Having an actual bionic prosthetic that can help them interact with the physical world around them is also helpful. And how about giving afferent input back to an amputated nerve? Will that help? I think that's also another big next step for us. So with that, I want to thank my partners, and I want to thank Max and Richard Brannemark as well for agreeing to collaborate with us and being such great partners. I'll stop with that. Thank you very much.
Thank you, Jaimie. I think it's your questions are going to be a lot of the discussion points starting tomorrow on the Phantom Limb Pain Conference. So I hope you can join the panel sessions.
I'll try. I'm so sorry. When they saw that I canceled my travel, they booked me in clinic today, and I'm in the operating room tomorrow. But I'll pop in if I can, for sure. I wish I was there in person with you guys. Sure.
We'll be addressing. I have some potential answers for those questions. So I'll be happy to hear what you think about that and some other people in the community. We have one question from the audience.
Yes. And the question is, are the pain outcomes any different in patients who have previously had persistent pre-operative pain and have undergone a successful arm transplant?
So what I will say from my own experience, Paolo, please provide your own experience. Our patients who have chronic pain prior to transplant, that pain usually does improve after the transplant. It may not resolve 100% because as they're undergoing nerve regeneration, they'll have new and different pains. With rejection episodes, they can also get pain as the immune system attacks those nerves and they get demyelinating injuries and maybe potentially worse. And so that also is a sticky point. But I'll say two things. In our experience, people who had lots of pain that required pain medication, sometimes they were self-medicating with alcohol and other things. That got much better as their nerves started regenerating into the transplant. It doesn't completely go away for folks who have really serious, horrible pain, but it gets much better. But we also have a very small number of patients, and so it's not a statistically valid, study to try to do a comparison on. So what you're getting is, my personal impression from it, and not a p-value.
Right. Thanks a lot, Jaimie, for joining us. And now we're gonna take a break. We'll come back at 4:40 Swedish time. Continue with the surgical talks. And thanks again for joining us, Jaimie.
All right, thank you guys very much.